Josh is the CEO and co-founder of Medic Mobile, a nonprofit organization that works to deliver software into the hands of community health workers to help them, help families and households. We're going to hear about that work, the work of community health workers today. Medic Mobile software is open source. They currently support more than 20,000 community health workers in effectively reaching more than 12 million people. So with that, I hand it over to you, Josh.
Thanks, James. Thank you. Thank you all. It's tremendously exciting for me to be here with you. We have true experts here, and you'll hear from them. I thought that I would take a quick 10 minutes to just frame this question, and then I decided that was a terrible idea. And I'm going to start instead with stories, and I'm going to ask each of our panelists here to share a story of their health system from the perspective of a health worker or a citizen in their system. I'm going to start with Alinafe and then ask a few other panelists to join us.
Good morning, everyone.
And I'm sorry, could you introduce your name, your organization, your role, and then tell us your story?
That's fine.
Thanks.
Good morning. I'm excited to be here. This is my first car forum, so very excited to be here. I work with VillageReach in Malawi, and basically what we do at VillageReach is we try and find solutions and test them and see how they impact on improving provision of quality healthcare. And if something works, we work with governments and partners to take that to scale in a sustainable way. So I want to start off by just telling you a story in terms of this one woman whom I've interfaced with in Malawi, and her name is Elena. Elena is 31 years old, I think, and she had been having persistent headaches and general body weaknesses, and she did not know what to do. Elena lives an hour and 40 minutes away from the nearest facility, and this is representative of thousands and millions of people in my context in Malawi in terms of the distance to health facilities, and that it's much easier for them to go and talk to a traditional healer than it is to decide to take that journey to walk to the nearest facility. So having been experiencing these symptoms, Elena called the hotline, which is called in Chichewa, which is my language, in English would call that health center by phone. It's a toll-free hotline. And when she called the hotline, she talked to a trained nurse who is, we call them hotline workers. And the hotline workers, using the protocols at the hotline, was able to ask more questions. And then, I think from the questions that she asked, she encouraged Elena to go and seek immediate health care because she suspected that Elena might be pregnant. So Elena, of course, took some time, but she went to the facility where it was confirmed that she was pregnant. And having seen the advantage of calling the hotline, Elena then called back to register for tailored tips and reminders, which are basically messages that are sent at intervals according to where you are in your stage of pregnancy to help you in terms of the most important actions and behaviors to take. And after delivery, she also then registered for tips and reminders for under 5 children so that she would also receive messages in terms of what she would need to do to take care of the under 5 child. So this story is representative of many, many women in Malawi, which is where we work. And I think one point I'd like to highlight here is that by calling the hotline was able to provide another touch point to the health system. So it did not, replace the health system, but provided another touch point that then she could call on. And then, while at a health facility, maybe she would have had maybe 60 to 90 seconds to talk to a provider. She had the opportunity to talk to a hotline worker for 15 minutes or more to provide more information, to understand what was going on and to ask more questions. So what we see, I think, in this case, is an example where this technology is providing, the simplest of technologies, just a phone call, is providing an opportunity for people like Elena to call in, and so they can, access information and advice around the health issue. Thank you very much.
Thank you, Alinafe. Fantastic. Amazing. So I think that we do have additional mics for the rest of our panel. Consolata and Kishore, I'd love to hear about your work. We'll start with maybe Consolata. Could you tell us about what a typical day is like in your work?
Okay, thank you once more. I'm Consolata Juma from Kenya. I'm a community health volunteer in my community. Okay, first we used to do our work manually, but when we were given the phones, we installed an app called MOH Siaya, because I'm from a county called Siaya. It helps us to do registration at household level. We do register all household members, but when we register a woman who is of reproductive age, you'll get a question asking, is the woman pregnant? You'll answer yes or no. If she's pregnant, has she started an antenatal care support at the facility? If we say yes, you'll get a question when. And after writing the date, you'll get another question. When will our next visit be? Then you write it. And when you register children under 5 years, you'll get the schedules for immunizations, because when a child is given birth to, the child has to be vaccinated, first vaccination being BCG and birth polio, that is at birth. Then the next immunization, okay, after having written that, you get the next question according to the age. Because we give oral polio at 6 weeks, that is first oral polio. The second oral polio at 10 weeks, the third one at 14 weeks. So as you'll be visiting the child, we'll be getting the tasks. Having the phone will be reminding you of the age of the child. Okay, according to the age, there are the immunization schedules for the child. So when the child is of an age when he or she is to be vaccinated, you'll get a task. Even now I have tasks in my phone. In 2 days' time, in a week's time, you should go and do a follow-up to check whether the child was taken for immunization. And when the child is sick, we do assessment. We have our tools for assessment. We have we call our MWAC, that is mid-upper arm circumference, that is used for assessing the child. And we do even, we treat malaria at community level. We have our kits for testing malaria. And after testing, if the child is positive, we dispense at community level because we are given the drugs there. So using the phones, it has eased our work, because we used to do the work manually. We used to carry big registers, heavy ones, to the community. But with the phone, I just have to use my phone because I'll get all the tasks here. When I see the task, I just have to go do a follow-up to the household. Then if the child was taken, I just enter the date when the child was taken. And if the child was not taken, I have to refer the mother to the facility. There isn't a place where referral is to be done. And after all referrals, I have to do a follow-up again to confirm, was the child taken to the facility or not. So I really appreciate Mbindyo Mobile for the work it has made us to do easily, because, okay, our main target in Kenya is we have cohort 1 and cohort 2. Cohort 1 is an expectant mother and a child and a newborn to 2 weeks, and the cohort 2 is a newborn to 4 years, 11 months. So our main target is expectant mothers and children under 5s. We don't expect mothers to die when they're expectant. So we really encourage them to go for early NCs. First, we encourage them, we prepare mothers for conception. We don't just let them conceive unknowingly. We prepare a mother for her conception. After conception, we make sure she goes for early ANC visits, early antenatal care visits. And we make sure that every mother goes 4 times to make sure that in case of anything, in case of any danger sign, refer them to the facility. And in case of anything, we make sure that a mother does not die at this age. And we make sure every mother delivers at a facility. Because before, mothers used to deliver at home. And this really used to risk their lives. But as now, even if you go to Kenya, you'll find the majority of women, I can say 99%, do deliver at facilities. So I would really appreciate Mbindyo Mobile for the work you've given us, for the work you've made it easy for us to do at community level. And in Kenya, every CHV is to manage 100 households. That is an approximate of 500 people. I work within my people, because that is where I stay. In case of anything, I'm contacted. In case of anything, I can even call an ambulance. I have a success story. When I had a neighbor who was expectant, she had a labor pains at night, so she called me. When I went there, I called my boss. I call my boss Cha. That is community health extension worker. When I called him, he gave me a number to call an ambulance. I called an ambulance. The mother was picked and she delivered at the facility. So it is very important that all mothers at all levels, they deliver at the facility. And we make sure that all mothers, we make sure that they look after their children. We don't encourage, it is a crime for a mother to die when expecting and a child to die between the age of 5 years. Be blessed.
Thank you, Counselor. Thank you, Consolata. And Kishore, we'd love to hear about your work as well.
मेरा नाम किशोर कुमार है। मैं बैरपुट कॉलेज तिलोनिया में कम्युनिटी हेल्थ का काम कर रहा हूँ। मैं ऐसे गांव में काम करता हूँ जहाँ स्वास्थ्य की सुविधा प्रॉपर नहीं पहुँच पाती है, तो मैं वहाँ हमारे वहाँ के कार्यकर्ता प्लस दाइयों के साथ मिलके डोर टू डोर जाके एएनसी का मैं मेडिक द्वारा रजिस्ट्रेशन करता हूँ और उनको स्वास्थ्य की पूरी सेवाएं देने का प्रयास करता हूँ। साथ ही जो 9 महीने के दौरान जो 3 जांचें होती है उनकी मैं जांच करता हूँ, जैसे यूरिन, बीपी और एचबी की। तो ये जांचें करके मैं उचित उनको मार्गदर्शन देने का प्रयास करता हूँ और डॉक्टर से सलाह भी लेता हूँ। वैसे मैं बैरपुट डॉक्टर भी हूँ, तो मुझे छोटा मोटा दवाई का बेसिक थोड़ा जानकारी है, जैसे आयरन है या पैरासीटामोल है या आयरन फॉलिक एसिड है, तो ये दवाई मैं उनको वितरित भी कर सकता हूँ। और बायोकेमिक सिस्टम के लिए मैंने वहाँ तिलोनिया में ही ट्रेनिंग लिया और बायोकेमिक सिस्टम की दवा भी मैं देता हूँ, जिसमें एएनसी के लिए 26 नंबर जो सरल प्रस्तुतिकरण के लिए है वो दवाई मैं उनको प्रोवाइड करता हूँ। और मुझे खुशी है कि आज मैं ऐसे गाँव में काम कर रहा हूँ जहाँ स्वास्थ्य की सुविधाएं उपलब्ध नहीं है। और शुरू में जब मैं वहाँ जाता था तो लोग मुझ पे विश्वास नहीं करते थे, लेकिन मैं उनके साथ लगातार जुड़ा तो आज उनको मुझ पे पूर्ण विश्वास है और वो मेरा पूरा विश्वास करते हैं और मैं अपने कार्य को कंटिन्यू लगातार कोशिश कर रहा हूँ।
Thanks, Kishore. And thanks, Magnus.
I'll just give you a quick summary of it. He's Kishore Kumar. He's a community health worker working with Barefoot College since 1998. So he is currently using Medic Mobile registration system to register pregnant women. So the way our system works is that we have a local grassroots champions in each of the villages where we work. And Kishore Kumar, when he visits all the villages, makes sure that he registers all the pregnancy, and through the Medic Mobile reminder system, what he's trying to achieve is that we register pregnancy is the first trimester, so that we identify all the high-risk pregnancy very early, so that he's also a barefoot trained doctor, so he can give some basic medicine. For example, if someone is diagnosed with anemia at an early stage, he is trying to go door to door and motivate them to take iron and folic acid, making sure what Consolata told, that at least 3 antenatal visits. That way we are able to see, and he's able to see a major change in how we are providing antenatal services to the women around. One more thing he added is that he started when people didn't have trust on community health workers, but he persisted going to them again and again, build that trust, and now when he goes back to the community or anything, minor ailments to any pregnancy, he's the first one to be contacted. So he's very proud of the work he's doing for his own community.
Amazing. Thank you. And Kishore, you told me you joined Barefoot College in 1989. Is that right?
Yeah, I first joined
It's amazing.
1989, but I'm
Amazing.
continue working in 1998.
Yeah, amazing.
Yeah.
So I'm going to ask the rest of our panelists to maybe we could tell 1-minute stories about current systems. If we go down the line, starting with Angela. Thank you.
Great. My name is Angela, and I serve the team at Financing Alliance for Health as their leader, or better known as the chief troublemaker. My story will be based on my time in government and just maybe a bit of context of my motivation for doing what I do today. I was serving the government of Kenya as the District Medical Officer of Health in Garbatula many, many years ago. And at that time, just a bit of context, Garbatula is eastern north, which is in the semi-arid area. It's predominantly pastoral communities. At that time, there was no road, no water, no electricity. FGM and child marriages were more than 95%. And we were sent there as the formal health workers, right? Based at static facilities to deliver services. Our health indicators were dismal because at certain times of the year, which could be up to 6 months of one calendar year, we would see less than 5-10 people in our static health facilities because they're pastoral. They move with their cattle to look for water. We are formal health workers. We sit in static facilities waiting for them to come. So as you can see, there was a bit of a mismatch of service delivery and expectations. And so what we realized as a team was that to improve our services to the community, we needed to think out of the box. At that time, we did have organizations within our jurisdiction, non-governmental organizations that were working with community health workers. And, they were doing good work, limited scope of work in mostly the, specific areas. But what we needed them to do, for example, in Garbatula, we had the Kenya Red Cross was doing amazing work, but mostly focused around Kina, which is like the most urban area in Garbatula. We needed to deliver services to Modagashe and Gubatu and Sericho. And so we decided to engage the non-governmental health workers. So the government requested a meeting with the non-governmental organization, and we aligned and said we want to do what we fondly referred to as desert caravans. What that meant was that we would use the NGO, government-trained, by the way, government-trained community health workers who are working with the NGO to deliver services to this pastoral community. And so we would match the group of community health workers with 1 or 2 facility-based formal healthcare workers, and we would give our team the registers, the drugs, the commodities, and they would go and perform mobiles and outreaches for about 5 to 10 days in a month. And the good thing is, I was working in that community. I'm not from the area. I don't understand the culture as much. I don't understand the migratory patterns of the pastoral community. But it's my responsibility to ensure that they have access to health services. But the community health workers, they're from the community. They understand. They used to say, now we need to move to the watering hole here because that's where they're going to go. And working together with those non-governmental organizations, it was win-win. For the NGO, they're able to demonstrate that they're working very well with the government. They're able to increase their scope of work in terms of people served, in terms of services offered, in terms of their impact. For government, we are delivering on our mandate as people who are responsible for ensuring that as many people within our jurisdiction of the country access healthcare. So the 2 things I want to say is, 1, thank you. Thank you to Consolata. Thank you to Kishore. Because I think it's sometimes in some of these settings where community health workers are not institutionalized, there's never that significant recognition from the formal health sector. So as a person, because I'm no longer able to speak on behalf of the government, I would like to say thank you very much for the important work that you do. And secondly, for me, it's the motivation now to work with governments, in developing countries to make sure that we do recognize this contribution of this kind of stuff. This is us trying to reach all people. Every health workers have their role, the nurse, the doctor, the lab worker, and also the community health worker. So let's recognize that role, let's support that role, and let's ensure that we facilitate those particular roles. So thank you.
Magnus,
Oh, right, okay. Yes, my name is Magnus Conteh, and I'm the incoming executive director for the Community Health Academy with Last Mile Health. I used to work with World Vision International in the Dublin office in Ireland. I will just give an inspirational story very quickly of one incident in Sierra Leone. I come originally from Sierra Leone, and as part of my work, we were training community health workers in a district called Bont District. For those of you that know Sierra Leone, there is an island called Shabro Island, which is very difficult terrain, difficult to access, riverine conditions, and to access some of the remote communities, the community health workers would need boats to access those communities. So we had constructed, through the program I was managing, which was an Irish Aid funded program, we had constructed a speedboat that could help to move women and community health workers from one destination to another. But there was one situation where a child was very ill, very unwell, and the mother, of course, had about 5 other children to look after. So she couldn't really take the child to hospital. So the community health worker volunteered to take this child. He carried this child on 2 boats and walked 5 hours, eventually got to the health facility. And after the child was seen, it was discovered that, in fact, the child needed some blood transfusion. Now, there were no blood transfusion services there. There was no blood bank, no blood saved in order to be able to do this transfusion. So the community health worker was given this information and was told that this child needed urgent blood transfusion. He didn't know what to do. So he said, well, what can I do? How can I help? And he said, can you take my blood and see if it will work for this child? And indeed, they took the community health worker's blood, and fortunately, it matched the blood type of that child. So he donated his blood for that child to be saved. And indeed, the blood transfusion went ahead, and that child's life was saved. Now, that's commitment for you. Now, I get paid for doing what I do. Community health workers don't get paid in most communities. So I'm passionate about professionalizing community health workers and advocating very strongly to make sure that they are incorporated into the formal health systems and that they are adequately compensated for this level of commitment that they show, a case in point that I've just given to you. So I'm passionate about this, and if we can digitally empower them to make that access and that referral, in fact, because if that community health worker had a phone, he could have called for that speedboat and accelerate the access of that health facility for the treatment of that child. Thank you.
So good morning. Very hard stories to follow on. My name is Caroline. I work with Living Goods. My story is also about distance. When Alinafe and Magnus shared, they're talking about great distances. My story is about short distances. One of the branches that Living Goods works in is in a place called Port Victoria, which is on the shores of Lake Victoria. And the community lives around the branch. The health facility is within, I would say, the recommended 5-mile radius of the community. But what does 5 miles mean? For most of these communities, for them to access the health facility, they can take a boat, which takes them about 7 minutes, but they don't because the boats are not safe. They can drive across a bridge, which would take them about 11 minutes, but they don't because the bridge has been under construction for the past 2 years. They can take public transport, which takes them about 47 minutes. That's what most of them do. 47 minutes does not sound like a long time, and it isn't, relatively speaking, but public transport is not available. So it's only available at certain times of the day. And when you talk about public transport, it's somebody's personal car, which they have transformed into a local taxi, which fits 11 people, some of them who sit in the boot. So when we talk about short distances and we think because the distance is short, then we have improved access, it's not always the case. So how do we define distance? And what keeps me and my colleagues awake at night at Living Goods is, what is our responsibility to our fellow brothers and sisters in the countries that we work in? How can we improve the systems? What technologies are available? What processes do we need to look at? How do we engage with our government partners, our fellow partners in community health, to really ask these hard questions, to understand where are these communities, who are they, and what is our responsibility to them? So that is my short story.
Thank you. So what I'd like to do, given we could talk for hours, I am sure of it. We have a short time together. I'm going to ask a question of one person of the panel, and then have the panel discuss for a few minutes, talk about a couple questions, and then open up at least a half an hour for engaging with this audience here, which I think is really important. Caroline, I'm going to turn right back to you and ask you a difficult question, I think. Why are we talking about technology, given we've known what to do to deliver basic services and care for people for decades, and we've had massive failures in delivery and failures of really moral imagination in delivery? Why are we talking about technology? Why have we assembled this panel?
Mm-hmm. I think in the breakfast session we had this morning, Lisha said something really important. She talked about building cathedrals. And I think all the people who have used technology previously in health and in community health have, left their brick as part of the cathedral. When you look at real life problems, they are complex, they are ill-defined. It's not easy to find out, so what is the solution? And we do pieces at a time. So if you look at, we are living in an era where technology is more pervasive than ever. The cost of mobile technology specifically is going down every day. Technology users, from my grandson in the city to my grandmother in the village, are becoming more tech savvy. Governments are, more amenable than ever to the power of technology, mobile technology, simply because of what it has, done in other industries. In Kenya, in the financial sector, in the retail sector, mobile technology has transformed, these sectors. So we are moving away from looking at, technology as a hammer, looking for a nail, and really trying to understand, what are we trying to grapple with? What is the issue that we are trying to solve? So really saying, how can mobile technology be used to support community health? How can it be used to improve diagnosis of illnesses like malaria and diarrhea and pneumonia? How can it be used to register pregnant women? And when we are registering them, also triage them to understand who is at high risk and who should be referred to health facilities. Once they are referred, how can they then be followed up on consistently until they have a successful birth and they leave that health facility alive with their child? How can we really look at providing support to community health workers? I mean, in the private sector, we look at incentives for people who are providing services. In community health, we look at volunteerism. So how do we provide incentives to community health workers who are providing services to hundreds and thousands and millions of households? How do we then monitor the service, the quality of services they're providing? Because this is life and death. How can we not monitor the quality if they're providing life and death services? So what tools can we provide to the community health worker to support them as they are doing diagnosis and treatment? How can they check the quality of services that they're providing? How can their supervisors check the quality of services that the community health workers are providing? How can the supervisors be supervised? Using the data that we're collecting, how can we incentivize all the players in the system? And how can then we build systems that result in performance-based pay models for development? So not just looking at, give me money, I will do something, but I will deliver results and you can pay me against the results that I am delivering. And this model has been seen to reduce under 5 mortality by 25%, over 25% at $2 per person. We are now looking at how do we institutionalize this model? How do we work with our government partners, with other partners in community health to really grow and scale the impact at low cost? So for me, I would see technology as something which has evolved, as technology implementers as understanding the problem more every time that we work. The data that we have been collecting over the years, using that data to really influence how programming is done, to understand what sort of partnerships, sort of coalitions we need to bring together to address this challenge.
Thank you. Others, what do you think? Why are we talking about technology in the context of failure to deliver basic medicine, for example?
Well, despite medical breakthroughs that we've seen over a number of decades now, we still have 6 million children still dying from, treatable conditions. We hear from WHO and UNICEF that, in fact, half of the world's population doesn't have access to medical treatment. Nonetheless, we know, as my colleague just mentioned here, how the mobile phone penetration has got into a number of countries. Developing countries, a lot of the communities have access to mobile phones than they have access to clean, safe drinking water and electricity. These phones are already in the hands of community health workers. They're in the hands of community health workers that we have here on the panel, who have given examples of how they can use these phones to register women, to make referrals and counter referrals, to collect relevant data that is given to decision makers to help to inform either diagnoses from clinicians or from managers making supply chain management decisions at a much more rapid pace and with greater efficiencies than we've seen before. The challenge, though, is how do we take this to scale? Already, the technology works. There are great examples here from what we are talking about. Here I am, I have a tablet that I carry around with me. I have access to all sorts of information. I have a smartphone here. Community health workers have smartphones which are not as sophisticated as this one, but nonetheless, they can still make phone calls and ask for help and advice. Supervisors could contact community health workers and give guidance and support. So we know the technology works. The challenge, though, is that how do we now take this to scale? And this is where the audacious project, for example, and the funding that comes from a whole host of philanthropists here can actually help us to accelerate the enabling of community health workers, empowering them with digital technology to accelerate the help and the reach of healthcare provision at the last mile. Within the Community Health Academy that has just been launched, we will be leveraging technology to provide training for community health workers delivered onto the mobile phones that they already have, that they're already using to collect data, to make phone calls, to make referrals, to undertake some diagnoses, so that they have in their hands, they don't have to travel several miles or go and stay overnight or a week at a time away from their families to have face-to-face traditional training. But that this mobile technology could be used to provide them ready-made training that is also digitized, it is enhanced, it has multimedia facility that they can use to actually see live examples of signs and symptoms that could help them to make diagnoses. We're also going to be using an e-learning platform to train and support the government leaders who support community health worker programs in order to ensure that they have good examples and good exemplar case studies from other countries as to how to manage successful community health worker programs. So we need to take this now to scale, and then finally, we need to build research capability around those programs in order to be able to demonstrate the impact on health outcomes. That's going to be the challenge, but it can be done.
Thank you. So, thank you. So relatively briefly, I want to turn to Angela and Kennedy and Alinafe as well. Comment on the role of government. How should we be thinking about that? How are we interfacing with and actually accompanying governments? What does this look like in reality?
Thank you very much, and I'm really looking forward to hearing my government colleagues speaking a little bit towards this. I think looking at government, and just to also building on your question, Magnus, how do you go to scale? Governments, by nature of who they are and what they do in countries, they are at scale. So, my challenge to my team and also to people is, how are you engaging governments? And, are governments just informed of what you're doing, or are governments, at the center of your programming? Are they involved? Are they also leading in that aspect? But what I would say is, I think about the role of governments in 6 ways, maybe the G6. Government as a scaler, government as a convener, government as a coordinator, government as a sustainer, government, yes, I'm going to say this, government as a co-founder and facilitator of the different technologies we're coming up with, and then government as a human resource mobilizer. So let me explain each of this, and then I'll ask Kennedy also to speak. Government as a scaler. I don't know if that's right. To take to scale, that is what I'm trying to refer to. And I mean, once political prioritization is, once it's secured at the government level, the government has the ability to take a project in a limited geographical area with, subject that to funding, to make it into a program and an initiative. The government can take what your team is doing in one district with 100 or 200 community health workers and make that a national priority and make sure that there are 100,000 community health workers. If you truly believe that what you're doing in that scale, at that level of scope is going to have impact, engage government. They will, and many governments are open. Many governments are open. The second one, government as a convener. Let's be clear, the convening power of the government is quite significant. I mean, I think obviously Skoll is doing a really fantastic job, but in country, very few people hold that power of bringing different stakeholders at very short notice in one particular area. And how do we leverage the convening power of the government? Government as a coordinator. We all work in this space of community health, and we're doing fantastic things as organizations and as teams. Many of the times, we don't have full visibility of what each and every one of our organizations are doing. We have the plans and work plans and project papers online, but the true motivations, the true objectives, we may not have visibility on that. The government has this role of bringing different stakeholders together and helps in terms of asking people to share what they're planning on doing in a country. And with that level of visibility, there can be coordination, there can be collaborations, partnerships. We can reduce the fragmentation and improve the synergies that can happen across our different organizations. Government as a co-founder and facilitator. Yes, I want to state here that governments are actually contributing to some of these programs, irrespective of their income level. I want to say that it's happening in South Africa, where most people would expect it to be happening because of their status, but it's also happening in countries like Malawi, where despite of the income level, the government is committing up to 17 million USD every year to pay community health workers. So the government is willing and able to contribute to these programs. Of course, once the case is made, once they're involved. And please note, they need to be aware of the kind of impact that these systems are having on ground so that they can make that decision to work together and partner and collaborate. Government as a human resource mobilizer, right? In most countries, especially developing countries, the government is the largest workforce in that country. Okay, and so, it trickles down Ministry of Health and so on and so forth. And I mean, we may have different opinions on a number of things, but let's be clear, there are people in every district, in every geographical space in a country that has a civil servant. Every space. Now, that is not something that a non-governmental organization or private sector could potentially achieve. And I'm not talking about headquarters, I'm talking about at the actual level. How are we leveraging that resource that the government actually has? And then across all these aspects, how do we incorporate technology to make sure we are well engaging the government? But if you'll allow me, I'll ask Kennedy, please, to speak to the role that government is playing in this space.
Thank you. Thank you very much, Angela. My name is Kennedy Odhiambo. I'm a public health officer working in Siaya County, that is in Kenya. Now, I believe our partnership with Medic Mobile, of course, and the particular key role of the partnership was that Medic Mobile was to came up with the application that, of course, we used in the funds that we gave to our community health volunteers. These particular funds, we also got them through a partnership with the Bill and Melinda Gates Foundation, through UNICEF. And of course, the main aspect was supposed to be used to report community health activities, because like Consulate had said, they normally do household visitation every month. And then this particular data is sent in to, of course, DHIS2. This is a platform for health information within Kenya. So through that particular level, then it's used for coordination and also decision making. They did this at the primary level using manuals. That is manually using this particular booklet she was talking about. It took more time for us to be able to make decisions. So that's why through this particular partnership that we had with Medic Mobile, at least the time has been shortened, because this is now real-time data. Anytime that a task is sent to the community health volunteer and also to the healthcare worker at the facility level, then decisions are already made at that particular level. So government as a co-funder is again very key. I think in Kenya, Siaya County has really tried within the allocations that they've given to the health sector. We are able to at least motivate our community health volunteers. We give them around $30 in a month. That is for the house of visitation, and also pay for them NHF cover, that's National Health Insurance cover, for both inpatient and outpatient at that particular level. The main reason for this is that we had realized the kind of work that they're doing within the community, and I think I'm one of the people who is joining Magnus in trying to say that we should not call them volunteers again, but we should now start calling them community health workers like we did later, because basically whatever they do doesn't really mean little. It means a lot. On the aspect of the human resource, of course, within this particular partnership, we are able to motivate and retain them with that particular little incentive that we give on a monthly basis. And I know there's an aspect of scale up. In my county, we have 100% coverage of community health volunteers, meaning each and every household is covered. One community health volunteer covers 100 households. So that is a very good intelligence network for us in terms of advocacy and also communication. And that means that we have like 2,148 community health volunteers who are covering around 250,000 households within the county. Now, within our partnership with Medic Mobile that has run for more than 1 year, we are only able to cover 1,000 community health volunteers. As we talk currently, we are through the partnership with other stakeholders like AMREF and UNICEF. We are trying to bring on board all the other stakeholders who are also seeing the importance of technology, of course, in reporting health aspect and also in improving coordination of care, so that we are able to scale up to the whole county, now the remaining community health volunteers. Of of course, this particular application, because we just picked some few key indicators to be able to monitor closely, it has made other partners and stakeholders who are also looking at some aspects like nutrition to also want to be able to also monitor their particular indicators on a real-time basis. And through that, then we've again worked very closely with Medic Mobile for the, of course, production of an app that now will incorporate all these particular indicators that are very key to this particular process. Now, our partnership, the importance of this particular partnership is that there's that contribution from each, is a synergetic kind of partnership, whereby also the government gives in some contribution, and of course, Medic Mobile, they will just come up with the application, train our own staffs, the staffs that Angela was talking about, that we as a government, our civil servants, who are the ones trained as troubleshooters and also as system administrators at that particular level. So within that, then we are able to retain that particular knowledge down there, and also it will help us in the aspect of scale up. So the main aspect here is within this, with the use of these mobile phones, when the community health volunteers use them at that particular time, at my level, then it's easier for me to do coordination of care. It's easier for me to, of course, do real-time decisions that, of course, are based on evidence that they send in. So thank you very much.
Thank you, Kennedy. Great. Fantastic. So I would love to hear from Alinafe about your partnership with government and really the national scale-up in Malawi, and before opening it up for questions.
Yeah, thank you very much. So I think a lot of good points have already been raised, and I'd like to say that, basically one of the things that we're facing, so when you talk about challenges, that we have a lot of pilots that end up as nicely written, journal articles and reports. And what is very important is to think through in terms of how is that going to be taken to scale. And I think this is where government comes in. And we at VillageReach believe in a highly collaborative approach in working with government, but also other partners. So I think how that looks like is that we're engaging government from the beginning in terms of defining that problem and working with government to provide leadership throughout the intervention, which makes it easier when we think about scaling up, because as it has already been pointed out, government in most of our countries, Ministry of Health is the largest provider of health services, and they're ones that are recruiting health workers. So we know things can be cumbersome, things can be slow at the beginning and throughout implementation, I think, when we're working with government, but it's worth engaging government from the beginning. So I'll give you an example quickly in terms of the hotline, the health center by phone, which I've already talked about, which in Chichewa we like to call Chipatara Chapafoni. And from the beginning, we worked with government in defining the problem and working with them then to pilot that initiative in one district. That initiative went up to 9 districts. And what has happened is that working with government now, we are in the process of transitioning that to the Ministry of Health. So they've taken it over. And in taking it over, what that looks like is that instead of just looking at the 9 districts, which is where we were at, they are taking it to scale in all 28 districts. So we have a toll-free hotline that the Ministry of Health has taken over to scale to cover the whole country in Malawi. And so that's how partnership should look like. I think that's just an example that from the beginning we've engaged them, and working with them, then we define in terms of where we want to go, and also then define clearly in terms of how that scale up will look like. And so in Malawi right now, by 2019, the government would have fully taken over the Chipatara Chapafoni, and it will be accessible to everyone in the 28 districts, because government has been able to provide leadership from the beginning. Thank you.
Wonderful. So I'm gonna come back to us for a 1-sentence final question, but before that, let's spend at least 15 minutes talking to you all. Questions, please.
Yes, hi. I'm Marjorie Newman-Williams from Mary Stopes International. So a 2-part question. We've talked a lot about children 0 to 5, and we've talked about women being pregnant, but there's a whole population of people between 5 and being pregnant whose health needs aren't being served. So how are you using technology in that area, and how are you helping women who don't want to be pregnant?
Fantastic. I'm going to start. Well, maybe do you want to start?
Yeah, so when community health workers go to a household, they don't only register the pregnant women and the children under 5. They register all members of the household, and they provide the mandated services to all members of the household. If you look at specifically family planning, that family planning services are available to women of reproductive age. Officially, I think that is between 15 and 49. But in Kenya and in Uganda, in the two countries that we really work in, we see that those services are provided to children as well. So people between the age of 11 and 50. So the services are offered to them. They are made aware of the different forms of family planning that are available to them, depending on what the government allows. For example, in Uganda, they allow cyanopress, the self-injectable. Our community health workers actually provide these services to the women who are choosing that contraceptive method, and then following up to them with them for continued uptake of the service. For women who prefer other forms of family planning, that is offered to them. Some are available from the community health worker, and some are only available at the health facility. So depending on the preference of the woman, then the community health worker advises them on what action to take. In countries where cyanopress is not, or injectables are not available, for example, like Kenya, what we do is we provide the other methods, and we inform them of where they can get long-standing family planning methods, but we also work with government to engage them to see how can we get these other methods that have been seen to be successful in other geographies to start being provided by community health workers in the countries that we are working in. We also look at not just family planning, but also counseling. Why should a girl who is 11 years old be pregnant? Why should that be happening? So how do we engage with our communities, our village elders, our health facilities to tackle the challenges of children, girls, who are getting pregnant when they shouldn't be getting pregnant?
Great.
My name is Kevin Jabo. I work for the University of California, Los Angeles, but I'm from Cameroon in Africa. It's what I'm trying to see. It's we look at it from different perspectives. We see from the panel, you're starting from Malawi in Kenya and East Africa to Sierra Leone. There is always this huge gap in Central Africa, which we don't understand what's going on, and that area of the world is always ignored. And then I'm trying to see is when you're talking about different countries in Sub-Saharan Africa, do you try to see how you can connect those countries? How we just look at country levels and district levels. What happens to communication? It's very easy to leave from Libreville to France than to leave from Libreville to Yaoundé. What is the problem? So how do we connect those sub-Saharan African countries?
So very good question. At the Financing Alliance for Health, we work with several developing countries across different geographies. So, we do work with countries in West, East, South Africa, and now in the Caribbean. To your question specifically around how do they learn from each other, one of our roles is to ensure, because we do support governments in thinking through how health systems and community health systems at that can be sustainable. And so we work with ministries of health and finance. We help them, develop investment cases for their programs, because they need to advocate for monies from within government, which is, domestic financing is going to be the key to sustainability, as well as from different stakeholders. And we provide platforms where different government delegations are able to share their experiences. And just to give an example, we received support from the Rockefeller Foundation to host several country governments at the Bellagio Center, and then we brought global financial stakeholders. And it was raw, it was governments, ministers of health and finance telling stakeholders, yes, you give us $2 million, but you want us to do this small thing with this one activity. As a Minister of Health, I want to reach more than children and women and pregnant. I want to reach the men. I want to reach the vulnerable communities and the marginalized teams. And the governments are able to say, look, we are grateful for your $2 million, but the order of magnitude of our need is $200 million in over 5 years. And then they're able to share across different governments on how they've been able to mobilize resources domestically from Treasury and other line ministries, as well as from global stakeholders. And then global stakeholders are able to say, you know what, sometimes, governments, you and your timelines and your creative accounting, and and we are able to have that platform where people are able to engage, and it's a safe space, and but we actually have true and actionable next steps. And right now, from that Bellagio meeting, we're about to potentially launch financing in one of the countries. We are working with a multi-country instrument that we hope to launch very soon that will help to fund what this kind of initiatives we're talking about at scale, in terms of thousands of community health workers, in terms of nationwide coverage in several countries, in developing countries. So yes, we do provide that platform for learning, for engaging, for challenging each other, which is also required, and also to exchange ideas.
Thanks, Angela, please.
Yeah, let me just add very quickly to that, indeed the international community has a role to play in connecting these various countries and supporting kind of regional approaches, but also regional blocks that have been established, like ECOWAS, for example, in West Africa. And in East Africa, you also have the East African Commission. As a matter of fact, the East African Commission, cognizance of the kind of mobility that you refer to across the region of their citizens, have now supported the establishment of what they call the VillageReach roadmap, which is looking at how digital technology could be used to support the development of health services across the East Africa region. That initiative is headed by Professor Gibson Kibiki. And Last Mile Health is actually on the steering committee. I'm sitting on the steering committee to support that initiative. And a number of other organizations, USAID is funding that. Some other organizations are on the steering committee, like PATH, and ensuring that a regional approach is taken in terms of how we could strengthen health service provision using technology, of course. In West Africa, similarly, a roadmap was developed about 5 years back. Unfortunately, because of lack of funding, it really didn't take off. But currently, there are discussions of pulling together international partners and donors to support the West Africa roadmap. I hope for Central Africa that I don't have an example to give you, that a regional bloc in Central Africa could also look at something like that. Now, what the Academy would do, and we intend to do, is how do we take learning and experience from these various regions and bring people together, maybe in communities of practice, as a way of exchanging ideas, or looking at exemplar countries or regions that have done very well in that area, and how could we use that as part of our training programs. So I'm afraid I don't have something more concrete to give you for Central Africa, but certainly the Academy will be interested in talking to your regional bloc.
Thanks. We'll take a couple more questions. We'll go to the top. Maybe we could ask maybe 2 questions. I see Jenny has her hand up as well, and Aaron.
Hi. I'm Micah Reich, and I'm here representing the Grameen Foundation. And Grameen also has done a lot of work in mobile technology for community health. And we have programs in India and in Ghana, for example, where we worked with a consortium to develop a crackerjack tool that's doing great work and is now being scaled up with the Ghana Health Service. And so one of the things that strikes me, and in talking about the idea of a community of practice, is that there's so much great work going on, and it's been fantastic to hear these examples. And we are all here together in this forum to combine forces. And there's competition that goes on for funding and for gaining traction with our particular apps, and yet we're all working for the same goal. So I would just challenge us to think about and talk about, and maybe the Academy is playing a role here and there are others that are doing so, but how do we come together and share our tools and our best practices and our best examples and really collaborate instead of exchanging about it, talking about it, and then going back to our little corners and trying to figure out how to take ours to scale. How can we work together to truly take this to scale on a regional or global level?
Thank you. Amazing.
Thank you. I wanted to thank the panel because you did such a phenomenal job of sharing stories that help to illustrate the role that technology can play in accelerating health systems and making them more effective. But in my personal experience, I often see that there seems to be a disconnect between the interest of philanthropy and bilateral funding in technology and sometimes a failure to acknowledge that technology in and of itself can't function without an underlying system to help accelerate. So I just wanted to ask if you could share your thoughts on how we as a collective community could do a better job at helping to raise the understanding of that fact that technology as an accelerator needs to be applied to an underlying system, and that we also need to be generating and supporting and sustaining those systems. Thank you.
Thank you. Tim Wainwright from WaterAid. We work on the provision of water, sanitation and hygiene in quite a lot of countries around the world. And of course, as you're all aware, this is a key preventative strategy for the spread of diseases like Ebola, cholera, as well as combating antimicrobial resistance. I wanted to say one very quick comment, which is we're a huge fan of community health workers, and we've had a fantastic collaboration in Nepal integrating hygiene promotion messages into a vaccination and rotavirus vaccination program. It's been really effective, and it's getting rolled out nationally. And I just wanted to express huge support for what you were saying about the role of community health workers. My question related to some rather shocking statistics that came out earlier this year. I'm sure you're all familiar with this, but the leading academic institution that looks at healthcare facilities and the provision of WASH and healthcare facilities, the University of North Carolina, highlighted the fact that in developing countries, 55% of healthcare facilities lack running water, 40% don't even have soap. Now, I would be horrified by that kind of data at household level, but this is in institutions. This is where women go to have cesarean sections, you know. And I visited healthcare centres where the hand washing facilities are 300 metres away from examination rooms. So I'm just interested. My question is, any thoughts on how to? That's a systems failure, yeah. This is the sort of thing that should have been sorted out 20 years ago. We've known about these basic things for so long. So any thoughts on systemic approaches to tackling that, and or the role of technology in reporting, data collection on the provision of services? Thanks.
There's so much here. And you know, I think one thing that's really important to say is like collectively we're hearing those comments. You know, let me just comment briefly that we have some really disheartening studies that were released a few years ago that looked at the transition from outlier results to scaled programs in community health, specifically for diagnosing and treating sick children in the home. And it's integrated community case management. We saw large-scale funding and large-scale expansion, and studies looking back 5 years in Malawi, Burkina Faso, and Ethiopia. And those studies showed zero change in under 5 mortality. Does not match what we thought and what we saw with the outlier studies or with the initial studies. And I think we as a community need to learn from that. And to Jenny's point, I mean, what we're talking about here, by and large, is health systems being redesigned and people doing things differently. And then a discussion about how technology and basically what the things in humanity's toolkit might serve them and support them. And so my wish really for technology, and my question to round out this panel is going to ask everyone to comment on their hope for the future. My hope is that the outlier results that we're seeing with Living Goods and with Muso and with Pivot and Hope Through Health and a number of others, their tremendous results become the norm and become supported by technology to be just the default settings and normal everywhere. So that is what I see the core role of technology being, is supporting the system change and people doing things differently, and community health workers being paid and supported in that. So I think that, just to share my perspective on some of those comments, I want to turn to the panel, and we have 5 minutes. This is absolutely the start of a conversation, so we cannot take all of the questions. But I would really like to hear, starting with Consolata, could you share with us your hope for the future? And we'll go through everyone.
Sit here and share your future with us.
Please.
Thank you. Okay, as I said earlier, I told you that we do household registrations. We do even other things that are not in the funds. Let's say like sanitation. We do check if the households, they have functional latrines and washing facilities, because hygiene has to be practiced from the household. And as I told you earlier, that this is the place where we stay. We do work within our communities. This is where I work daily. These people, they know me. I have their contacts, and they have my contact. So in case of anything, they contact me or I contact them. So in case there is an issue whereby someone has to go to the facility, I'll have to call or go in person, because I don't walk a long distance. It's just within my community. So I know, this work, it is having the passion for it. It is a work that you're not forced to do. Doing voluntary work is something that has to come within someone. You have the passion for it. We do it lovingly, and we really enjoy the work. So as we go back, I know we'll still do the work with my fellow CHVs. And as I heard, okay, first we used to be called CHWs, community health workers, but as of now in Kenya, we are volunteers. But I know as time goes, we'll be workers. Whether we are paid or not, we'll still work, because you have our people at heart. Be blessed.
Kishore, would love to hear from you as well. What are your hopes for the future?
फ्यूचर में मैं समझता हूँ अगर डिजिटल टेक्नोलॉजी अगर हो जाएगी तो ग्रामीण स्तर पर जो भी प्रेगनेंसी के दौरान महिलाओं को कोई भी दिक्कत आएगी तो उसको आसानी से सॉल्व किया जाएगा, क्योंकि सारा काम पेपरलेस हो जाएगा और डिजिटल टेक्नोलॉजी से तुरंत इन्फॉर्मेशन जाएगी। इन्फॉर्मेशन के आधार पे हम उसको तुरंत उसको स्वास्थ्य की सेवाएं दे सकते हैं।
Kishore, I think, reinforces how technology is helping him provide better services. So he wants more technological support to community health workers at last mile settings, so that they are effectively providing services, reach out to more people than ever. So that's his hope for the future, that no person is left behind where he is working.
And to our panel, the rest of the panel.
Right, so I think, in my opinion, I think we definitely need a system that works for everyone, and certainly at the last mile, making sure that everyone has access to quality healthcare. And I think in that, I'd like to highlight that point, that we are not in competition, and that the strength of our partnerships will define our success, all of us, with governments, but also with each other, because that would be the way to go to scale up in a sustainable way. And also, 3 things that I'd like to highlight then is, one, of course, how do we empower our community health workers with the necessary tools, including the technology that they need? And I think in Malawi, using the example we've given, is providing another touch point to the system that communities can call upon. How do we address rampant stockouts of essential medicines and vaccines? In Malawi now, with government, we're testing the use of drones in terms of how do we deliver blood and oxytocin to save lives of women during labor. So there are some initiatives which are gaining ground. But also, lastly, I think what is important is how are we using data at different levels to make sure that it's supporting smart decision-making amongst all of us. So I think what we're looking forward is that strong partnership with governments, but also with each other as we explore in terms of the extent to which technology can have an impact in improving quality healthcare. Thank you.
What we have seen from our work and what we all know is that quality healthcare saves lives. The question is, how can we leverage technology to provide quality healthcare at the doorstep of the people who need it? How can we have the Uber of healthcare, where patients can call for a service provider and the service provider can come to their doorstep and provide them with quality service that they can afford at the time that they need it and where they need it? How can we cooperate and how can we collaborate? I think with technology specifically, we've talked about many of us developing different tools. How can we really collaborate meaningfully? How can we develop standards-based approaches where what somebody else develops is standard-based, which means I can use it and I can use it for different use cases, instead of each of us building our own solutions? I think that is the real challenge. We've talked about data, we've talked about performance management and incentives to community health workers to really recognize the work that they do and the difference that they make at community levels. We've talked about engagement with government, which is key to scaling, but it's also really key to ensuring quality at a large scale. I think for me, that is what I would like to see.
Let me say that in terms of solution providers like, Grameen Foundation, another Medic Mobile and Dimagi and other organizations that have been in this space for quite some time, I have seen a great shift in moving towards greater collaboration and harmonization of our efforts and standardization in terms of the development of technology for it to be open source and interoperable, particularly being interoperable with government solutions, so that the data that is collected by community health workers in our various programs fits into government systems where that data really should sit to inform decision-making at that level. I have had the privilege of working with Grameen Foundation in a collaboration through other work that I've done in maternal and child health, as well as the Ebola vaccine trial that's going on in Sierra Leone, where we collaborated with yourselves and bringing in also additional technology, not just for communication, but biometric technology to identify recipients of vaccines. So I see an increasing move towards that type of collaboration, but also in terms of NGOs and other partners in this space who try to do the same type of work supporting governments. Increasingly, there is an alignment behind government priorities, so that government is setting the agenda and we align behind government and supporting them. Now, for some time, because of the competition that was mentioned for limited resources, we've all gone into our different siloed kind of approaches to secure the funding that's available. But increasingly, as you can see, from the Audacious project, for example, from the collaboration between Living Goods and Last Mile Health, and other collaborative efforts with Co-Impact, even donor community is now moving in the direction of pooling resources together to support programs that can be taken to scale. So what I see in the future is greater collaboration, greater harmonization of our efforts. Within the digital health space, you hear about the principles of digital development, guiding us into looking at reuse and improving existing technologies, instead of us all going our different ways, trying to develop new platforms, new technologies, naming them after our children or naming them after our villages. How helpful is that to governments? And I have to say that in my last 7 years of being in the digital health space in particular, increasingly governments are now taking responsibility of putting controls in place and having e-health coordinating hubs, wherein if you want to go into a country to introduce a new solution, it has to be vetted to see if there isn't already another solution in the country that works. Why bring in a new solution? So I see a future where not only technology bringing us together, but actually government leadership. And those of you who are familiar with the Broadband Commission report, it talks about government leadership bringing the Ministry of Health and the Ministry of Information and Communication, providing that leadership for digital health development. That's what I see in the future, increasing but supported by our donor community as well, who do not continue to fund vertical programs, but collaborations like we have been talking about at breakfast this morning.
Thank you. Great. We are just over time, so Angela, could you bring us home and share your vision?
Okay, I'll try and be brief. Fingers and toes crossed. One, my hope for the future is that the brilliant minds in this room who are coming up with amazing technology act as incubators for impactful solutions, and then act as technical advisors to the government institutions that are able to take that impactful solution to scale. So that's the first dream. The second one is that funders collaborate and align and then co-invest and align their investments so that, again, as a government, it's easier to actually have impact. And as the Financing Alliance for Health, we have several financing solutions for scale programs in governments, and we're happy to speak to that. But there are many other ways to fund. The third is that we have true collaboration, that people who are not within government, that we can truly collaborate, not just in word, but in space deed. And then the fourth is that all health workers are recognized for the role that they play. All health workers, not just some health workers. Thank you.